I'm not a technologically adept person, and it happens every time, but thank you for the opportunity to present to you today. And I'm going to follow on a little bit from what Aidane's been talking about. I too am a genetic counsellor, and I work at the Garvan Institute for Medical Research in Sydney. And today I'd like to talk to you about a platform that we've set up to support researchers to return clinically actionable genetic results from research. Before doing that, okay, here we go. I would also too like to acknowledge and respect the traditional owners of the lands where I live and work, which is the Ma and the Wadawurrung peoples. They're the traditional owners of the Great Ocean Road, lands, waters, seas and skies. And I extend that acknowledgement and respect to anyone in the audience today of Aboriginal or Torres Strait Islander ancestral background. So what I'd like to talk to you about today is that we know that researchers are increasingly using genomic technologies in their research. And I think as Aidane presented before or talked about before, genomic research may not be a primary aim of the research. It might be a secondary part of the research. But when you do genomic sequencing in human research, there's this increased likelihood that you will discover secondary findings. And secondary findings, we talk about them as medically actionable genes or changes in genes that are actually unrelated to the initial reason for doing the research or the primary condition that the person has presented with. I'm definitely going the wrong way, sorry. So the thing to point out is that the likelihood of finding an incidental or an actionable finding in a research participant is below 10%. So it's relatively low. It's about 1 to 6% of individuals, and it really depends on the cohort, the way they're ascertained, and it could also depend on their ancestral background. This issue of how and ways to return this information to research participants is very much part of a whole international discussion at the moment, and guidelines are emerging about returning actionable results. And in America, in Europe, there are policies developing, and in Australia, as Aidane talked about before, we've got the national statement, which talks about returning secondary results, that the participants must be given the option to know the results, but also not to know the results. So there's a right to know and a right not to know. And if the results are disclosed, they must be provided with genetic counselling as well. So I think it's important to step back and think about, well, why return results? And we're actually talking about disease prevention. So we're talking about identifying people, many of them who are unaware that they carry these genes that cause a high risk of a condition, and also that they can inform their family members, and we can actually reduce morbidity and mortality from disease. These actionable genes and the information that we give back, we must have clear clinical evidence that there is actually something you can do about it. That's the current status of giving back the results at the moment, that there must be evidence-based risk management that people can engage in that can make a difference to their disease risk and ultimately reduce morbidity and mortality. Over the last 5 years, there's been in the genomics world, both here in Australia and internationally, there's been a lot of ongoing debate about what types of results should be returned. Well, firstly, should they be returned? What type should you return? And how should you best do it? It's really changed now, and it's really agreed that it's standard practice to return this information. But I think what's lacking in the statement, the NHMRC statement, is actually strategies to actually return those results. And the way you return those results is very dependent on the context. If you think about returning a result to a consenting adult, that's quite different to returning a result in a paediatric context. You also have to think about the rationale for the study. How long ago was it undertaken? Have people been consented to return additional findings? And as Aideen talked about before, sometimes genomics is not the primary aim of the study. So I'll give you an example. We're working with a Parkinson's disease group at the moment. There's a drug repurposing clinical trial, and they're only sequencing a subset of people with Parkinson's disease. So the primary aim is looking at drug repurposing. The secondary aim is actually the genomic sequencing. So I just thought I'd give you a little bit of background on preferences and what we know, what's the evidence to date about returning secondary findings. So research participants actually prefer to receive these findings, what we call medically actionable or clinically actionable findings. And it's across the board. It's if you ask biobank participants, they wish to receive them. If you ask patients, they wish to receive them. If it's a hypothetical scenario, people say that they would want to get them. And in some countries like America, some people, research participants, would see it as a prerequisite to them taking part in research. So no longer is it a one-way street where the researcher, I suppose, gets samples and undertakes research. Participants now have expectations about getting something back from research. One of the most important things to think about is the psychological impact. And genomic information has often been cautiously approached because of the concerns about psychological impact. Aideen and myself have worked in genetics for a very long time, and I would have to say there is clear and resounding evidence that really most genomic information does not cause psychological harm. It causes distress, but it doesn't cause long-term harm. It's more the disease itself and the experience that families have with the disease that is the burden for them. So if we look at the data on returning results, there's no significant differences in anxiety, depression, psychological burden. People adapt well. And of course, in the immediate period when they get that information, they're somewhat shocked because it was unanticipated. But over time, people talk about, and quickly, people talk about relief and value in knowing the information. They talk about feeling empowered, something that they didn't know, and that they can actually take action to manage that information. People choose to take up the results because really for their own personal health or that of their family, and that there is actionability, there is something you can do about it. The reasons they decline is one, they might know already. They don't want to know, which is a valid reason. And also people may be concerned about insurance implications, but I need to just point out that we do have a moratorium in Australia at the moment protecting people. And there is going to be legislation that will be drafted soon again, protecting people from insurance companies using genetic information to discriminate against people. You can see here that the uptake can be as low as 20% and it can be as high as 98%. And it really depends on the way in which you notify people. So just to researchers, to finish off how people think and what their preferences are, researchers also support participant preferences, and they should be offered to know that information. But they also cite that they can't do it themselves. They don't have training in communication, in risk communication. They don't have the infrastructure and the funding to do it. What's the Australian experience? So many, many years ago, we did a number of studies where we interviewed participants who'd been given back research results. And there are a number of factors that we identified that impacted on whether or not they took up those results. And one was the way in which you notified them. Two was that they actually had unmet information and support needs. And three, they encountered health system barriers to actually getting into a clinic to access the information. And so we would argue that genetic counsellors who are skilled in communicating genetic information, skilled in how to talk to families about this information, and also advocacy, should be involved in the process of returning information in high-risk scenarios. So we have established at Garvan a platform which is called My Research Results, which is led by genetic counsellors, and we work with researchers to actually return what we call primary and secondary genetic research findings to all Australians. So we connect researchers, research participants to genetic services. So what's the process that we use? First of all, we identify the genetic information, so we work with researchers to do that. We then post a letter to people in the mail, and we say that you took part in this study. You asked to be let you know if there was information available. We're writing to you to say it is possible that there is information available to you. Please call this number, and we have a 1-800 number that people can call and speak to a genetic counsellor. We then refer them, if they wish, to a clinical service, because the test must be undertaken again. It must be undertaken in a NATA accredited laboratory, because the first test has been done in a research laboratory, and very rarely it happens, but it does happen, that people have discordant results. So our platform to date, we've had contact with 416 people, as you can see, all around Australia. This is a virtual platform that we run based out of New South Wales, but you can see that we've returned results to people all over Australia. Mainly in Victoria at the moment, because they're the studies we're working with. And you can see that the range is 18 to 98, and the average age for people is 50. I just thought I'd take you through the conditions that we actually return. These are what called medically actionable. So we have hereditary breast and ovarian cancer, and you will have heard of these genes BRCA1 and 2, hereditary bowel cancer, hereditary kidney cancer. There's a condition called familial hypercholesterolemia, which is a form of cholesterol that's hard to treat and can occur in children and cause quite significant heart conditions. There are also cardiac disease and other conditions that we return results for. So I hope I've been able to present to you today that we have developed this two-tier evidence-based system to actually support researchers to return this information to their research participants in a way that provides the research participants with information and support. We're flexible and adaptive, and as I said, we have been working with researchers all throughout Australia. If you wanted to know anything more, you can contact us. We have a protocol paper. We also have a website, and you're welcome to either contact us or email or look at our information. So I'd just like to acknowledge our partners and thank all the great staff at the Garvan who've made this platform happen. Thank you very much.
Thank you, Marianne.